Testing.
All right, we're good. Ian, you told me earlier there was going to be no mention of ICD-10 here today, so. Thank you very much for the introduction. So, before we get started here, how many people here are already participating in PQRS? Don't be bashful, I know it's 9 in the morning here. Okay. How many people have not even heard of PQRS before today? Okay, good. So, what we're going to do here is, I'm going to tell you a little bit about what PQRS is about, and I'm going to tell you how you can create your own PQRS plan for your office, okay? All right, so PQRS started in 2010. Back then it was called PQRI. PQRS stands for the Physician Quality Reporting System. So this is where quality first started to get into the fee-for-service model. So as a lot of us, especially in the billing world, were very scared when the ACA came out. We thought it was going to be the death of fee-for-service, that we were going to be very much in trouble for our jobs. So what we're learning is that fee-for-service is not dying, it's dying maybe as we know it, it's changing. So we're still going to have fee-for-service, but a lot of quality initiatives are coming in. We're going to see this continuing. They have this mapped out all the way through the mid-2020s at this point. So it's not dying, just like ICD-10. No matter how much you might hate it, because we all might, it's here, and you might as well hug it, get used to it, get comfy with it, because it's not going anywhere. It's a voluntary process. Let's see, there we go. So it's a voluntary system. You don't have to, it's not mandated, you don't have to be a part of it, but you will be penalized if you do not participate in it. Okay? So what Medicare is saying here, and this started with CMS, it started with specialty societies, it went through IPAs, PHOs, and other quality-based groups. And what they said was they want to find a way to reimburse you for the quality of service and punish people who maybe have lower quality of service. People who are just kind of pushing things through. And so through these societies, what they decided to do was come up with a system so they could, it started off very simple. So those of you who joined in 2010, it was something as simple as if a patient comes into the ED with chest pain, you need to make sure that they're getting an aspirin. And if they're not getting aspirin, why aren't they getting an aspirin? And that's basically all it was to begin with. So for those of you who started then, it's been slowly growing, becoming more of a complex system where now you have all sorts of different ways to report it. And for those of you who are getting into it right now, because maybe you're starting to already be penalized by CMS, it may seem like a mountain at first. That's why a lot of people will outsource the PQRS side of things. But what I want you to do is understand what the process is so you can create one. You won't create one today here, but you'll have all the tools that you need to create one when you get back to the office. It's definitely a very time-consuming and scary process when you create it the first time. So it's provider-focused. A lot of you know that in the hospitals they have, they're trying to reduce readmissions, 30-day readmissions, 90-day readmissions, length of stays. So they want you to stay in the hospital less time, but they don't want those patients kicked back in a short period of time either. So they've been pressing the hospital. They've also been pressing the providers since 2010. A lot of people are just hearing about this now because the penalties are coming through. So how important, so Medicare sponsors, so I know there are a lot of people here that, like Kim and others here who are part of PD practices that might say, well, what do I care about this? It's a CMS initiative, Medicare isn't maybe important to my practice. What you need to know is that other commercial payers are also adopting these quality measures, all right? So, and they're gonna follow CMS's lead. So if you're not aware of that at this point, you probably need to get in touch with your commercial payers. Because if they don't have a system already, especially the big ones that you care about, they're gonna have one soon. They're all gonna be following the step. And it's gonna be very similar to this. So again, if Medicare is not important to you as a payer, and right now you might say, well, it's only 10% of our business or 0% of our business. What do I care if I get beat up 2% on something like that? Maybe it's not important to you now, but at least it's worth for you to pay, so don't walk out on me yet, please. It'll hurt my feelings too. But it's good to pay attention to understand how they're running the system, all right? Because it's going to hit all of us. Here are the bonuses and penalties, how they've been over the years. So in the past, these are the bonuses you would get, and now these are the penalties we're looking at. And through the rest of PQRS, which PQRS is ending in 2018, just like meaningful use and a lot of those other first quality initiatives that came up with the provider side of things. But they're not going away. Any of you who have heard about MIPS? MIPS is going to be the next thing. You know how we've been so scared about ICD-10 for a long time? All the conferences coming up are going to be about MIPS. And that takes all these quality measures wraps them all up and basically puts it on steroids and creates this hulking monster called MIPS that's going to be all, yeah, exactly, I'm seeing the faces already. So
what does that stand for?
I don't know what MIPS stands for off the top of my head, but basically it's going to be, it's a Medicare launch program that's going to start off giving like 5% potential. It's a revenue neutral model. So providers who are compliant can get 5% bonuses. Providers who are not compliant will be offset with a 5% penalty. That's why I'm saying we need to embrace this at this point. It's here and it's not going anywhere and it's going to hit everybody. Who is it hitting? Basically everyone already, physicians, therapists, and even non-physician practitioners. This is a list of them. Without going through it, basically, if you're on the Medicare Part B fee schedule, you're affected by this. So now let's talk about how we're going to create your own program. The lion's share of what you have to do is in the first part right here, choosing the measures to report. And this is the part that's the scariest. When you open it up, there's hundreds of measures that go across all sorts of specialties. The file is it's about just shy of 700 pages long. So when you open it up, it is scary. And then you have to choose your reporting method. There's several different, I think we're going to go through 5 different reporting methods here, and we'll get surface level information so you understand the basics. It should allow you to make the decision on what's right for your practice. And if not, you can always go to cms.gov, which we all know is a very easy to navigate site, right? And like we said earlier, I mean, we're all here this is my second year in the MGMA. I'm very proud to be part of this organization. If for some reason you've been tooling around cms.gov for a couple hours and are about to lose your mind, because I'm pretty sure all of us have been there, feel free to shoot me an email or contact me, or we can talk after this and I can give you my information. I'll shoot out, if you want to have a quick link to the measures or cross-cutting measures and the other pieces of the products, I'll be very happy to help you out with that and save you a few hours of your time. So then you choose how you're going to report it, and then then I'm going to go through how I think is basically our process when we're training billing staffs or providers on what they need to do to change the way they're currently documenting, and then how we're going to submit claims, and the feedback reports, of course, and the measures change annually. So the reporting period is always a 12-month period. Their reporting period is from January 1st to December 31st, so it's calendar-based. And it's important because if you're doing a measure like the flu shot, you and I would think the flu season is from October to March, right? They think because of January to December, the flu season is from January to March and also from October to December. All right, so you just have to get calendar dates in mind for that. And I checked this morning, they still haven't released the new measures for 2016, but it should be coming out any day now, and they'll start on January 1st. 254 measures. You're going to have to choose 9 of those 254. Okay? How do we do that? There's 6 different NQS domains. 3 of them you have to meet. You have to have 1 cross-cutting measure. Basically, what this is saying is, I have a pointer for a reason. So this piece over here, all this really comes down to what CMS really cares about is they're trying to improve, really trying to cut costs. That's what a lot of the initiatives that CMS is pushing out is trying to focus on. And they're trying to do it through these are the methods that they're trying to cut costs so that they're paying out less. All right. So you need to cross at least 3 of those when you're selecting your measures. One of them has to be a cross-cutting measure, which basically means face-to-face, but they'll have a list of what they consider cross-cutting measures that you should be following. So when you open up the PDF and you have these 700 pages, how do you start? Anybody know what Control F does when you're on a page? Okay, Control F becomes your best friend in this situation. So you want to care about CPT codes or diagnosis codes that are important to your practice. Print out your top 10 CPTs, your top 10 ICP codes. And when you search for them, say for instance hypertension is your top diag. You just do a Control F, search for hypertension. Maybe 3, maybe 5 measures will come up that are focused on hypertension. Go through them. Find out if they accept your CPTs. Maybe they're going to be hospital-based, maybe they're clinic-based. Find out, make sure that, if you're dealing with SNFs, make sure they have the SNF codes in there. After that, they'll give you a demographic of the patient. Is the patient between 6 months of age and 18 years of age? If so, then you're still going along with this measure. And then the final piece typically is what kind of a setting that the patient's in. Actually, I think that's my next slide here. Yeah, that's the denominator. So then they come up with these terms that put everybody to sleep called numerator and denominator because it makes us all think of math class, so I don't know why they use those terms. But it gives me these awful flashbacks. But so with the denominator, what they call the denominator, is basically just coming up with making sure that the measure meets what your patient environment is. The numerator is actually making sure that the measure is complete. So as we said earlier, if there's a patient that comes into the ED for chest pain, did they get an aspirin? If not, why not? And the if not, why not is going to be really the central piece for anyone on the administration side, which should be pretty much everybody here. So why didn't the patient get aspirin? And the numerator will be the part where you explain that. They'll have modifiers, 1P, 2P. Do we have that here? No, we'll get into that in just a second. But they have different modifiers that you can say, is it for a medical reason? Is it, so is the patient allergic? Is it for a patient reason? Maybe the patient says, aspirin makes my tummy feel bad. Okay, we're not going to give them aspirin, and the patient's refusing it. Is it for a system reason, meaning, say for instance, Caritas Christi, when they were around, they wouldn't provide reproductive services because they were owned by the Catholic Church. So they might be medically necessary, the patient might not be refusing it, but because of the system they're working in, they can't provide that service, or they can't prescribe a certain med. Another example with that would be poor access to a vaccine, say the flu shot. When the flu shot, when nobody has access to the flu shot, you might want to provide the flu shot, but you don't have access to it. So that would be a system reason as well. And then they also have unspecified. Any coders in the house understand how CMS looks at unspecified codes, the .9s? They don't like that too much. Okay. So, and I know this looks a little grainy here, but I wanted to show you exactly what it looked like from the report that you're going to get from the PDF. So here's measure number 6. This is for 2015. This is CAD, so coronary artery disease for patients who are 18 years of age or older. Let's say right up here, 18 years of age or older with CAD seen within 12-month period. So right here in the instructions it says needs to be reported once per reporting period. How long is the reporting period? 1 year, all right. People are listening to me, love it. 1 year is the reporting period. So that means you only have to hit this patient once in the entire year. And then you capture them for PQRS. All right, there's lots of other data here, but I only have an hour, and your attention span is going to last so long. So here we have the denominator. This is the part where they're going to say patient H, and to use these ICD-10 codes, these are the ICD-9 codes. They're saying you can use them from 1/1 to 9/30. And down here, once it becomes 10/1, they want you to use ICD-10 codes. I'm hoping everybody in here understands why that is. If not, then you have bigger problems than PQRS. You probably shouldn't be here. Go back to the other. Patient encounter during the report. Okay, so right here, let's skip to the other side. So right here, we have the CPT code. So I'm seeing 201, 202, 213, 214. Those are all outpatient office. Here I'm seeing some SNF codes. Probably getting into assisted living here, maybe home care, but you're not seeing any hospital codes. So those of you who work in a hospital system, this code is now dead to you. You can't use that measure once you see that. This is part of this should help you understand the measure when you're selecting the measures. Then we get to the numerator. The pink arrow is pointing to, although we've already read this several times where they just say patients who are prescribed aspirin. So it seems pretty clear, right? When the patient comes into the office, are you prescribing an aspirin? But here they get a little more detailed, and you see they're saying, are you prescribing aspirin, or if the patient's already taking aspirin. The reason why they're saying this is because they don't really necessarily care that you're doing something here, but they want to know because this isn't like someone's pushing medication and making sure that you're prescribing X, Y, and Z. This isn't like the medicine we're used to. This is quality of care. They want to just know. We just care that the patient's on aspirin. If the patient has CAD and they're over 18 years of age, they should be on aspirin on a daily basis. Okay? And we don't care if you're giving it to them or somebody else already put them on it. We just want to make sure that this is in compliance. And if not, why not? Medical performance, as we went over this a little bit before. So if they have an allergy, if they have intolerance, so they'll even give you examples for reasons why it might not be accepted. Okay. And then here's the AP performance not met, reason unspecified. CMS is not going to like that. So jump on any of your providers. So if you're working in the clinic and you have good access to your providers, then just ask them the next day why. I know you didn't prescribe aspirin to this patient. Why didn't you? And can you please document that in your note in case we're off? If you work for a billing company, shoot an email out, and just if you can get contact with them, basically you don't want to use APs unless you have to. Now the threshold they give you leeway on the threshold for how much PQRS has to be hit. It's 50% or greater. Okay, so you can throw in some APs. There may be a few where, let me just go back for a second, there's lots of diag codes here, right? So these are all having to do, so when they say CAD, they define CAD by anytime you use any of these codes, or even a couple V codes in here. So your staff might not pick up every one of those. Maybe they're used to using just a couple of CAD codes. All of these count. So a few things might be missed here or there. You just have to hit a 50% threshold or higher. And then the bottom part here, and this might not matter much to the admins here today, but for your provider, if they say something like, why is CMS trying to dictate what I do? What are they saying this and that for? They give you the rationale right up here. They're going to basically say, well, it's been proven that aspirin is going to prevent vascular events, and so it'll prevent them from having an MI or from dying. And we like our patients not to die, so that's why. And they even get into here things that they can put in their note. You can set into the EHR template where they say, okay, aspirin, here's a milligram dose, it should be continued indefinitely. So they give you a lot of good information here. So for once, it seems like CMS is actually doing a very good, thorough job helping us out. And I think that part is going to be good for your providers if they're resistant as well. Okay. Your submission deadline for PQRS for this year is February 26th. And again, if you aren't keeping up, if it's taking you February 26th, that's another thing, you might have bigger problems with PQRS if you're that backed up. And your modifiers, we went over this. And there's going to be a test on this, and I'm not lying. We are having case studies at the end for that CAD code, so I hope you're paying attention to this now. So we're going to keep you guys a better this one. All right, reporting on. Now we've done the hard part. So the measures now, say for instance, when you've gone through, figured out your top diags, you've gone through several measures, you've broken it down, say 15 measures or 18 measures. Now you're going to your providers and maybe even your billing staff, your administrators that are telling you, okay, these ones we don't even do, and you're throwing them out, and you now whittle them down to the nitty gritty. When you've selected your 9, you then go to, and I encourage you to reach out to your billers or the people who are very comfortable with coders who are going through these documents that know what's there. I mean, you might have 12 of them out there, and then one of your billers might say, hey, listen, we need to do these 4. They're just in the medication listing. We go through that every day anyway. It's not going to affect us at all. What you're trying to do is satisfy the requirement without limiting the amount of work that you're adding to your process, okay? So the different versions of reporting options, number 1 is claim-based. We'll go through these we'll go through each one of these in just a second. Registry reporting. EHR, if you have something for your EHR, or you can outsource it as well. GPRO, that's usually one of the pieces that people first hear about when they get into PQRS. It used to be for really large groups, but now it's for smaller group practices as well. And the Qualified Clinical Data Registry. So claims-based reporting, I think this is really comfortable, especially if you only have a few coders and you just want to add this as a new CPT code. Basically, it's a 5-digit code. You just add it like a CPT code on your claim. And then if you have a modifier, those 1P, 2P, 3P, 8P, you just add that as a modifier like you would any other modifier. It just goes out on your claim with a normal bill. You can charge $0.00 or $0.01. The total claim charge, and I put this in here because Medicare is not going to accept a claim charge of $0. And all your PQRS are probably going to be attached to an E&M, so the charge will never be $0. But I generally like to say put it in as 1 penny into your fee schedules because for whatever reason, who knows, some that day might come where you need to add it to your, where you might do a submission and it's only going to be your PQRS, maybe some type of link deal or something. So just to save you any potential hassle. And obviously you can't bill the patient the 1 penny. But one of the good benefits with claims is you can put in multiple measures on a single claim. So here's a claim form, and you can see in the orange arrow is pointing to 5 PQRS codes for this one patient. The purple arrow is showing you where it's being billed out at $0.00. And the blue arrow up above, and you can see the 99213 right above there. That's what you're actually billing out for the CPT. And now your DIAG code, where the blue arrow is pointing to, this diagnosis code better match up with all of those PQRS measures that you have delineated there, okay? If this patient is being treated for multiple reasons and they're dipping into multiple PQRS for that reason, you need to make sure you have all the diagnoses listed that are associated with that PQRS. All right, next reporting option, registry based. So this is like a web-based form where you can take a 20-patient sample. You can do it the traditional way that we showed you already with choosing the 9 measures, the 1 cross-cutting measure. Or you can report as a measures group. So they have these measures groups which are like, they can be 7, 8, 9, 10 measures, but they focus very strictly into a certain niche. For instance, fall evaluation. I think fall evaluation has 7 codes. And when you look into the fall evaluation codes, it's going to get deep into neurology and all sorts of other places that you need to make sure you're able to read, that your service provides all of the measures that are in the measures group. And if you need measures group list, it's also on the CMS site too. There aren't that many of them. And you can have a 20-patient sample. About a little over half of them have to be Medicare patients. But like I said, you have to report all the measures in the group. If you can't do it, then just go back to the 9 codes that we were talking about earlier. One of the benefits of EHR-based reporting, not only that you can outsource it, but it's the only way that you can monitor your progress. So a common question I get is, well, does CMS allow us to see what's actually going on? Can we compare provider to provider? Unfortunately, you have to still do that the old-fashioned way. When we started out in 2010, we would have all the coders, anytime we were doing an 8P, which means reason unspecified, all of our coders would take it to our coding manager. And that way we'd have one person handling all the 8Ps. That allowed us to track, okay, out of these 40 doctors, we have 3 of them that are just grossly not adhering to what we need. And then that way you contact the specific doctors that have a problem. But it's pretty slick to do. And also you have to make sure you're CEHRT certified. If your EHR has the ability, ask your vendor for the certification. If you're outsourcing it, ask them for the certification. Have it on hand so that when they don't do it, you can sue them. Okay, GPRO. So group practice reporting option. This used to be for 100 provider practices, 100 providers in a practice or more. And now it's come all the way down to even 2 eligible professionals, although they only allow you to go through their registry, the EHR, to use GPRO for the smaller groups. But now 25 or plus can use the web interface. And I think with all this, again, getting a little bit back into the quality side of things, the GPRO is where they're going to want you going. Claim-based are eventually going to phase out, and this is the direction you want to be in. So for those of you who have already been participating, maybe you're very comfortable in PQRS, and not that anyone wants to get out of their comfort zone right now, you have other fish to fry maybe, but if you do, this is a great place if you have a little bit of ambition to get to the next level, because this is where they're going to eventually want everybody to go to. And then there's a qualified clinical data registry. This goes beyond just PQRS, but it also handles PQRS, so I thought it would be important to bring it up as another option that you can look for when you're creating your program. Okay, so a lot of the registries might be good if you have a lot of coders and maybe you just want to have one person handling all your PQRS, just have one hub or 2 people rather than training everybody on it. So this one you have to report these outcome measures, and this all depends on what you're reporting. But if only one's available, you have to use a resource experience, a chaos safety, or efficiency appropriate use measure. And again, those are all also detailed. Unfortunately, we don't have time to get into the real nitty-gritty on each one of these options. But at that point, and I know that's a lot, we've just had a long walk on the first 2 steps, but that's 90% of the job. If you can stomach getting through that part, the rest of it is just training and implementation. And in this world, training and implementation is not a big, cross to bear. So I would just start off with the billing staff first, or your admin people, whoever's handling this. Explain the impact of participation. Let them know that we're going to lose money. 60%, we work in the SNF environment. 80, 90% of our patients are Medicare patients. 2% means a lot to us. You want to get a raise next year? Discuss new protocols. Let them know like I said earlier too, reach out to them. Ask them for help. Show them what you've come up with. Maybe even make them a little part of the decision-making process so they have a little ownership on it. And oh God, this is going to go bad here. Try to leverage most of the work on the admins. And to a crowd of admins, this isn't easy to say, but we all know why, right? Who do you want the work on, the providers or you guys? Who should the work be on? And I'm not saying financially because they're gonna get paid more than us, but what I'm saying is you guys will do it, and you will do it right, and they won't do it, and they won't do it right, right? Everyone's worked with doctors here? Okay. So, you wanna make it convenient for them. Like I said before, if they have access to some of this information, then by all means, make it as easy as you can on them. But you need to put as much work on their side as you can. Okay, good, pass that slide. On the provider side, create a simple process. Focus on the minimum requirements. All right, so I was talking to Alan earlier about this. You know, you don't want to have, if you say, oh, they need 9 measures, we're better than that. We can do 12 measures. Please, keep it simple. Do what the minimum requirements are. Ask the minimum requirements out of your providers. Make sure you satisfy what you need, but don't go crazy with this stuff. Okay, it's gonna get crazier, but let it come. So review the billing process. Let them know that the admins are taking 80% of the work off their shoulders. When you say, yes, you do have to do more documentation, they say, what are you talking about more documentation? Why do they care about aspirin? Say, listen, admins are taking 80% of this off your shoulders. Okay? All we're asking you to do is, when you have a CAD patient and you don't give them aspirin, we just want you to tell us why. And it's only for CAD patients. And it's only for aspirin, not any other medication for CAD, not for any other diagnosis but CAD. For the CAD patients, we just need it for aspirin. Okay? Let them know. I mean, I don't care if you tell them, if you show them that 2% of their Medicare is $600 or $6,000. When you tell them that it's going to hurt them financially, you show them how they are going to care. And reinforce with swift feedback is absolutely imperative. So once this program has started, you need to get back to them quickly. Let the people who are falling out of the range of compliance know that they're messing up. Show it to them and keep reinforcing it until they get sick of seeing your face and they comply. And again, make it convenient for them. If you have in your EHRs, add some templates. If you have super bills, add some check boxes, put some updates in it. Again, make it simple as possible for them. And definitely post something wherever they are. You know, you always have to post these sheets up there. And again, make it very simple. CAD, big, fat letters. And then just let them know the minimum that they need to do to comply. Death of PQRS, very morbid, you know, this would be more something to celebrate if I didn't tell you already it's going to be absorbed into a bigger monster, right? Which will go along with meaningful use. Yay, meaningful use is going away. No, you're not going to say that when you see what's coming. All right, so resources here. And how are we doing for time?
Half hour.
Good.
We're good? Okay, good. So here, the resources, it's all at cms.gov, okay? Here's my contact information for when you lose your mind. I like it in rainbow because rainbow is my favorite color. But it's all the information is on CMS. It has all the measures, all the cross-cutting, the measure groups, all that stuff is there. But if you want to just ask me, okay, well, how would you do it in an office like this? And feel free to talk to me maybe afterwards during the break or something like that. And the QIUR, those of you who are participating, are you guys getting your reports in September? Are you getting your QIUR reports that explain the benefits and all that stuff? Seeing a bunch of still eyes here. So if you aren't getting your report, you need to take this phone number down. And if you're not sure, you should take this phone number down. So when you participate in September, which is now, in September you get this report every year. So if you participated in 2014, your report is coming this month. If you've been reporting for years and you don't know what I'm talking about, please go back to your office and call that number and let them know that they're supposed to be sending you a report. The report is very detailed. I could probably spend a half hour just showing you how the report works, okay? There's lots of information. It's great though, you can compare provider to provider and understand exactly where everyone is. Okay, let's leave this up there for 1 second because I still see people right now. So how's everybody doing?
Also, our slides will be posted on the website.
Right,
There'll be
yeah, so
something
you can
on
download,
that.
yeah, and thank you very much for that. So please go to the MGMA website and use this as a guide for that as well. Okay, case studies, are we ready? It's gonna wake you guys up.
Can I ask a
Okay.
quick question
Yes.
first? So I'm in pediatrics, so I'm not participating in PQRS.
Yeah.
People who are participating in PQRS and adding these codes, are they sending these out on all their claims or just their Medicare claims?
If you're choosing, it's just for Medicare patients.
Okay.
And that's only if you're doing the claim-based way of
Okay.
submission, but yes, yeah. So this will affect all of your Medicare claims, any of your TUS patients, don't worry about them. Okay? All right, case studies. So we're following the same CAD thing, we're keeping consistent here. And for HIPAA reasons, I have stripped out names. I'm either doing like a first name or just a last name or just an initial or something like that. So I'm going to be asking you guys, we should have brought gifts for people who get this stuff right. Next time, if we get invited back. But, all right, so are they meeting the measure or not? And if not, why not? Is it for a medical, patient, system, or reason unspecified? I think the first gentleman's name, last name was T. First name, Mr. So Mr. T comes in, and is this patient 18 years of age or older?
Yes.
You didn't check his documents, people. Come on, we're in the medical field. You can't just look at people and check the documents. Anyway, okay. Patient's over 18 years of age. He's combative and scary. You tell him, hey, you need to have some aspirin. He knocks the aspirin bottle out of your hand and he says, shut up, fool! It says it right there. So he's refusing the aspirin. How are we submitting this to PQRS? Patient reason, perfect. Okay? He's combative and he's scared. Next one, also a Mr. T. First name is Ice. So he presents to Dr. Octopus with CAD. Patient comes in, he says, and you're trying to provide him with aspirin. He says, I'm allergic to aspirin. Medical, yes. Just because a patient said it does not mean it's patient reason. Good. So medical reason. That's the 1P. Next one, we'll just go first. Meatloaf presents to Dr. Zayas. Anybody Dr. Zayas? Please tell me somebody here knows who Dr. Zayas is. They blew the whole damn thing up. Statue of Liberty on the beach. Planet of the Apes people, come on. It's a tough crowd. All right. So Dr. Zayas prescribes the patient aspirin. How do we submit?
No modifier.
Just a code, no modifier needed. Okay, that's what we're looking for, right? All right, let's get some women in here. And then Opera comes in, and to Dr. Lecter, who is a very renowned Greater Boston physician. So Dr. Hannibal Lecter sees this patient, but there's been a recent recall of aspirin in the United States. So other than the riots that are popping up everywhere, because nobody can prescribe it for the next 2 weeks, how are we submitting this?
It's a system.
Very good. System reason. Okay, we only have one left. We'll go to Bono. So Bono's older than 18, right? So he comes in, he's seen on the last day that this doctor's working at the practice. So the doctor's he's documenting, but yeah, I'm not giving this patient aspirin. You can't contact this doctor, unfortunately. You can't, like I said before, reach out, email the doctor, or talk to them the next day. Patient's not prescribed aspirin, but you're not sure why. Unspecified, yeah. So this is where your 8P comes in. This isn't going to be a common thing that happens, I imagine. Doctors leaving, shouldn't happen that often, that you can't reach them and find out the reason. But if she left and you can't find them out and there's no real way to do it, feel comfortable using the 8P, that's fine. CMS just doesn't want this to be the majority of what you're submitting for PQRS. Okay? And then, yes, download this presentation. Yeah, so get the presentation from the website. Stop participating. So when I say stop participating now, it's actually a little bit too late to stop participating now. But for those of you who raised their hand when you said you don't have a program started now, you want to start the creation process now. It's going to take a while. Your January 1 is going to come up quicker than you know. It takes a long time to put a program together, especially for people who weren't incrementally going up as PQRS was going on. It's going to seem like a mountain when you start. It's going to be pretty tough. So I would say figure out how you want to start this, and those new codes are dropping any day now. Really check it at the end of this week. They might be tomorrow. So really any day now the new codes are coming down. Those of you who have a practice going right now with PQRS, if anything I said was new to you, hopefully it was. Hopefully you had something to learn from this. And fix your hiccups. if you have any questions that you're not sure, well, we'll get to questions in just a second too. And anyway, the bottom line, like we said, quality billing is just getting started. PQRS is really one of the first pieces to usher that in. Medicare is looking to cut what they're paying for fee-for-service by 10% every year, which means they're supplementing that, we hope, with quality payments. So if you can't do PQRS, you're going to be lost 5 years from now. Right? And I probably shouldn't have put it up here, goading emails like that. But all right, any questions?
We're good.
I
Yep.
wanted to clarify, you said that the fee should be what, 1 penny?
Yeah, the fee, it can be $0.00 or it can be 1 penny. Those are your two options.
Okay.
I suggest 1 penny just because because Medicare will deny any zero balance claims. So if there's ever an event where you're submitting PQRS, and I'm not sure what the reason would be, and you have only PQRS on there and you don't have your E&M or surgical procedure or whatever it is that you're doing in practice, if that's not in there with it, it will just get flat out denied. So I would just say, if you're able to adjust that fee schedule, just make the fee schedule 1 penny, and then that could save you from a potential hiccup.
Okay, because I noticed the claim form on the end.
Exactly, yeah, and that's from my office, so guess what I told them once I found that? I said, no, I don't like this one. Any other questions? Yes?
So you're starting to plan now for 2016 to
Yeah.
implement, and so you're going to send this information in early 2017. What penalty period are you avoiding by sending that information?
Great question.
2018 penalty?
Okay, I'm gonna try to go way back to the beginning here. Oh, I think I broke it. This is kind of confusing, so that's why I want to put the slide up. So you get hit with the penalty from what you did 2 years ago. So those of us who are being hit by that 1.5% penalty this year, that's you. That's because of what you were providing in 2013. Okay, so it's a 2-year grace. So when you start your program in 2016, you are taking care of your 2018. Okay? So that means you're gonna get hit for that 2% in 2016, and you're gonna get hit again in 2017. But in 2018, since you properly submitted in 2016, you'll be good in 2018. So for those of you who especially deal with cash flow, again, Alan, I was talking to you about this earlier. You know, where if you're looking over the value of a practice, valuation. I had a discussion this morning about that, and you find out that a practice doesn't have PQRS, or it's your practice that isn't participating in PQRS, it's going to devalue your company significantly. All right, you might not think it's that big of a deal, but wait till those evaluation people get in and start sizing you up. And say, okay, you haven't done it, so now we know you're not only going to be beat up this year, but also the next couple of years.
Does the 2% go away in 2018 when PQRS ends, or is that indefinite?
It will go so the PQRS program goes all the way through 2018, so it will affect you, although the PQRS program ends in 2018, it will affect you that 2 years later up to 2020. Yes?
Are those penalties cumulative, like they
No.
are with the incentives? No.
No. It's just set for what it will be, yep.
So if you're in an ACO, they should be doing that for, that's what my ACO told me.
There are some ACO, now, so there are some exceptions. There's very few exceptions to PQRS. Pioneer, are you in a Pioneer ACO?
No.
No? Okay, then you are governed by this. Pioneer ACOs, there's some, if you're in there's another thing to look into too. If you have a critical access hospital, or if you're in an FQHC, you might not be subject to this stuff. Okay, so no, those are only there are only a couple of instances when you're not going to be affected by this, but I would think your ACO should be helping you out with this. Absolutely. You should have
They
some.
told me, I got it right.
Okay. You can sue them, right? Good. That's all we care about. Yeah.
So do you have to bill through the ACO? Because otherwise, how would they have your data?
Do you have to bill what?
If you're not billing through the hospitals,
Yep.
then how would they submit data for you, other than say maybe?
Who's billing who's sending the codes in? You're talking about if you're doing a claim based?
Well, in other words, if you're a private practice and you are doing your own billing,
Yep.
but you're part of an ACO, but they don't have any of your data, don't you have to have
Well, a lot
data?
of times they do though, Jill. They, if you're part of an ACO, you're submitting
I think it's a conversation you should probably have.
Right.
And find out who's taking care of PQRS in your system. Because if you're not, if nobody's sure,
There's a lot of confusion.
yeah, and if nobody's owning it, then someone needs to own it, or it probably means that nobody's doing it.
That was my
so-
interpretation.
What's that? Yeah.
My
that's it.
interpretation would be.
We've seen that before, right? I think we got it covered. Yeah, don't worry about it. Yeah, we've seen that. So I would just say find out who it is that the bottom line is, because if they're not going to handle it for you, then it does fall on you, obviously. Someone has to handle it. Anyone else? Okay. Thank you guys very much. Anybody else who wants to talk about it, I'll be available during the break. I'll be here till noon. Thank you guys.